Okay, so it's great to be here. I was at the Wellcome Trust recently, and one of the people there who's in charge of international health said, just explain to me what it is you do. I've sat in on something and you're probably at the most extreme end of what we fund. And I suspect for this building I'm probably not what you'll commonly hear about, but I'll try and explain a little bit about one aspect of work that we get up to in Kenya that you may not hear so much about if you're on this campus, and not the kind of stuff that the tropical medical people have traditionally been involved in. Because my work has migrated quite a bit over the years, and we're now trying to do things at scale with the Kenyan government, and I'll explain why. So I'll just give a tiny potted history of what the program is all about for those of you who don't know it. I'll try and indicate how it is that we've come to be working on the areas we're working, and then I'll talk actually about what we're planning to do over the next few years. So the program in Kenya is now extremely large, as those of you who were able to get to the tropical meeting 10 days or so ago will know. There are about 850 people now employed through the Kenyan Medical Research Institute Wellcome Trust program in Kenya. So it is very substantial. A very large number of those are obviously involved in a demographic and surveillance system, so doing household visits. So it's not that there are 850 scientists, but there are now a good number and a large number of independent grant holders. And basically the whole program covers this kind of remit, and the globe in the middle is just to try and suggest that it's supposed to be an international centre doing international quality work. At least that's its aspiration. I operate down in this, what's your bottom left-hand corner, now in the health systems arena, but there is considerable overlap with a whole bunch of things. So my background is actually as a paediatrician, so I still have some role in clinical research and more general public health. But many people think of the Kenya program as being CALIFI, and that is the large part of it, but actually I've spent the last 10 years in Nairobi, and a colleague of mine, Bob Snow, who some of you know, have spent 20 years in Nairobi. So there is a long-established setup in Nairobi, and that's where I'm based. And there are now about 70 or 80 people in Nairobi, most of whom are about 50 researchers, but they're from graduate researchers upwards to postdocs and more senior people. The reason why we're set up in Nairobi is basically because we need to work with the Ministry of Health. So Kilifi is 600 kilometers away from Nairobi, and actually if you're trying to do things with government, it's just too far away. So in Nairobi we can sit waiting outside offices for half a day waiting for the meeting, which doesn't happen, and you're told to come back tomorrow, and it's not such a great disaster. If you've travelled 600 kilometres to get to that meeting and it's cancelled, it's a bit of a pain. But also when people talk about evidence to policy, it sounds like there's some magical formula, and there are quite a few frameworks. The bottom line of it, a lot of it is about sitting and meeting people and catching people in corridors. So it's very helpful if you're on the spot. So in Nairobi, most of the work tends to take a more national perspective and increasingly an international perspective. And if and when Bob Snow or Abdi Noor come and speak to you here, you'll hear about work all over the continent that they're doing from a base in Nairobi. In my particular work, we're also dealing with the medical school and increasingly actually with some of the professional bodies that are take some responsibility for health oversight in Kenya. In the past, they haven't really had much of that role because they simply weren't big enough, or just didn't have the mandate until 6 or 7 years ago. Kenya only trained 3 paediatricians a year, so the Paediatric Association wasn't exactly a substantial body of people. But they're now training considerably larger numbers of professionals, and these professional associations are have got more of a voice. So Nairobi is where we're based, and we now have to deal with a devolved health system, literally in the last months, to 47 different counties, each of which has its own county government and is now responsible for health service delivery. And that map in the bottom right-hand corner is the shapes of the different counties. I can explain the colours if anybody's interested. So the programme has been around for a long time. It'll have its 25th anniversary early next year. I've been around quite a long time. But the work has evolved over really the last 10 years, and it's evolved out of a couple of things. One is obvious failings with the health system, which would be apparent in many low-income settings. You may feel like you have problems with the NHS here, but there really is no comparison. You don't know how lucky you are. It's also evolved out of work trying to get evidence into policy and practice, and then actually how do you implement changes? That's particularly changes at scale. And that's a much more generic question for any health system. The context may be different, but some of the principles are generic. Out of our original work, which I'll now explain a little bit more detail, came this idea that we need something a bit more sustainable in terms of a platform for research going forward. And I spent some time trying to persuade people to give us money to set up a network, which I'll explain to you. And I'll give you an illustration of what we hope to be doing through that network. So this is work that I did with colleagues in the Ministry of Health over 10 years ago, which is where it all started, basically. What we were trying to do was find out whether anything that the researchers said was a good idea was actually happening. So there's been an awful lot of work over 40 years of what type of care should we be delivering, what drugs, what other forms of therapy, how fast we should be doing things, what equipment we might need, what technology might help us, etc., etc. The bottom line was, when we looked over 10 years ago, nobody in the real world had ever heard about any of the stuff the researchers did, and that includes what the WHO had been saying for 20 years. So there was an absolutely massive gap between what was on paper and what people were actually able to do in practice. Some of you may have seen this, I've shown this slide a few times, but this is actually a neonatal intensive care unit. Obviously it's not an intensive care unit, but this is where they look after very sick babies. So in that bundle of cloth on the bottom right is actually the baby. And they're trying to keep it warm by putting an open electric fire next to it. So clearly not that desirable in the 21st century as a form of therapy. This bit here is something that you use to resuscitate babies and is in theory life-saving. That one actually couldn't possibly work because it's supposed to have a nice soft face mask, and in fact all they've got is a rigid piece of plastic, so you can't actually use that to help the baby breathe if it can't breathe at birth. So they've got the appearance of care, but there is actually no possibility that it could work. So, and this picture sort of sums up many thousands of words, which essentially all said the same thing. We have the appearance of a health system, but the practice of the health system was so limited that it was probably doing little good at all. So we then spent quite a lot of time and effort trying to work with people at national level to decide what was appropriate and what was right. And I won't go into all of that, but essentially we started doing systematic reviews in Kenya and working with people in Kenya to take that evidence into local practice. So systematic reviews are obviously being done globally, but actually they often weren't the right type of reviews for practice in our part of the world. And part of the problem, although the Cochrane collaboration is wonderful, part of the problem is many of the things in the Cochrane collaboration, you can only do a review if there's a randomized controlled trial. So if there is no randomized controlled trial, there is no Cochrane review. And it's a tragedy in many ways that there are almost no trials in pediatric and neonatal healthcare. So if I was to look at the number of So in malaria, if you wanted, and we did this a few years ago, in malaria, if you wanted to look at malaria therapy, you could get over 50 randomized controlled trials of artemisinin-based combination therapies. So they've only been around about 10 years, and there's already 50 trials, and this was a few years ago. In neonatal care, if you wanted to look at what is the right antibiotic to treat a baby with severe infection, there are no randomized controlled trials. For giving the right fluids for a child with dehydration, there are no randomized controlled trials. For very severe pneumonia, which kills more children than malaria, there is one randomized controlled trial of 90 children, which was done in Turkey. And that's the evidence base for an awful lot of things in pediatric and neonatal care. I would hesitate to think how many HIV trials there are. But that's just, so we have to use evidence that's less than perfect, but still come up with what's the best possible guideline. And there's an internationally accepted approach now, at least, or one of these approaches is called GRADE, which is one we used. And we worked with a very large range, as indicated by the picture, of people in the policy and practice environment to make local guidelines. So the first generation of these was actually in 2006. We've now revised them into 2010, and in fact we've revised them again in 2013. And these guidelines have now been adopted in Uganda and Rwanda, and are being used with minor modifications in those health systems. The reason why I'm telling you about these is because these now provide the criterion by which you can say, we've agreed this is what we should be doing in the health system, and now can we do it? So that was quite a lot of work, simply to get to the point of saying, yes, these are the things we should be doing. We then had to develop a way to try and explain to people how to practice. So again, I won't go into all of this, but there is a course which has now been adopted really quite widely. I think over 2,500 people trained. It's now part of the undergraduate medical curriculum in Nairobi, and in Malago in Uganda, and in Kigali. And it's also in postgraduate teaching. But this was just to give people the basic skills that they would need to do the right thing. Because it's amazing what they don't teach you at medical school, including my medical school. So this was an enabler, so a necessary evil to develop this course. And if you want to know any more about that, everything is available on this site. So we actually initially developed the guidance and the training so that we could test whether you could really change practice. And we did this by randomizing hospitals to different packages of interventions. This is not done too commonly, randomizing hospitals, for reasons which I can explain to you if you're interested. And it was a bit of a struggle to get this funded, but it did eventually happen. But the bottom line is here that despite the fact that literally tens of millions of dollars are spent on it every year, and probably just in Kenya, let alone across Africa, we've known for the last 10 years that actually training people achieves almost nothing. So sending people on courses gets you nowhere. But yet that is pretty much the major intervention that's applied internationally to change practice. So you have to do things that go well beyond training. So what we used was these guidelines, which also include job aids. We used the training, but then we also put in place a system of feedback and supervision and something called local facilitation. And I won't share with you the results because this is just the background. But basically you can change practice quite dramatically with that package in a certain number of things. We were also able to demonstrate, in one sense, that doing this kind of thing is cost effective. So in fact, cost effectiveness analysis is a little bit of a black box in which some of the numbers that come out can be made to suit. But essentially, with plausible assumptions, it's doing this kind of thing is as cost effectiveness as most vaccines. So improving the way that care is provided, because there's a high concentration of morbidity and mortality in one place, is a highly cost-effective way to improve, to deliver care. So that was the main frame of our work in the past, but at the same time what we were trying to do is build up a team of people who could take this type of work forwards into the future. So we actually had both qualitative and quantitative researchers working in parallel, and trying to understand what the problems are in trying to deliver these types of interventions through the health system, because we randomised government hospitals. We are also, so the top is the qualitative methods, trying to understand what happens or how people operate, and what's the problem for them to do. And the bottom is a quantitative approach where we use multi-level models on data. So essentially we collect data on the individual patients and what happens to them inside hospitals, but because of the way in which we collect the data, we also collect some information on the clinical person who saw that patient. So there are multiple patients seen by a provider, and if across hospitals you end up with lots and lots of patients seen by lots and lots of providers. So in this subgroup analysis, this is just one question, we were able to evaluate over 1,000 patient episodes amongst 300 different clinical people in 8 different places. So this is 3 layers, if you like, in our models, which allow us to examine the influence at the hospital level, at the clinician level, and at the patient level with what actually happens to the patient. So these are methods that we've been developing to take forward, because they allow us to know where to target interventions. And then finally there's an issue about bringing quantitative and qualitative methods together, which is something that's becoming a bit more focused on in health. So more formally people refer to this as mixed methods research, which has got quite a long history in some disciplines but much less so in health. It's trying to learn the lessons from across different disciplines, particularly on how to implement interventions. So that was a whole bunch of work that took us from 2006 until 2010 to 11. What it led us to feel was that we've still got a real challenge for implementing better practices or introducing new technologies. We've also got a particular challenge of understanding what is really going on, because there are no health system data. So medical documentation of events in the health system is extremely poor, to the extent that in some recent work we did last year, almost 20% of hospitalized patients, it was unknown whether they lived or died. So there are pretty fundamental aspects of clinical documentation that are missing. For some particular subgroups, like the newborns, until we started jumping up and down, most newborns who were sick in hospital didn't even have a patient record. They were never given a record number. They didn't exist. They were a piece of paper inside the mother's folder. So in fact the system had no way of knowing how many sick newborns there might be, let alone what was wrong with them. There are also actually fundamental flaws in the way that the health information system operates. It was designed in the colonial era, and that same is probably true for much of Anglophone Africa. And it was designed to do 2 things. It was designed to count up the number of disease episodes there were, so that they could get some idea of what treatments they needed to be able to provide. But if you are an individual with more than one disease, HIV and pneumonia, HIV, TB, and malnutrition, then you are 3 episodes. And the system counts you as 3 episodes. If you die, then you die 3 times. So there's one system for recording how many disease episodes there are, which is independent of the number of people. And there's another system which records how many people there are going through a hospital, but it doesn't tell you anything about their disease. It just tells you that they were admitted to this part of the hospital, tells you what their age is and sex is, and then tells you whether they lived or died. But you can get no information about what they died from. And these 2 systems are completely independent. They're managed by the same people, but then there's no cross-relationship, so you can't get what is the malaria mortality rate in a hospital is actually an impossible number to calculate. What is the HIV mortality in hospital is an impossible number to calculate. Somebody will give you a number, but that doesn't mean to say it's correct. So there are actually fundamental flaws in the whole health information system. So we have this appearance, a very poor appearance actually, of there being information and us using it, or the ministry using it, but actually they don't use it, and they know it's rubbish. So there is a sort of ritualized process of information generation, throwing it in the bin and getting on with business as normal. But that's obviously a challenge going forwards. The other things are that Kenya and several other countries in East Africa at least are developing really pretty quickly, highly inequitably, but developing pretty quickly. So for instance in Kenya, I'm sure you're all aware that essentially 99% of health workers have a mobile phone, and in fact in some of a colleague's recent work 85% of mothers in rural areas have access to a mobile phone. So some things are happening fast. Other things are happening more slowly. I mentioned earlier that there's been massive devolution. I mean, if you think changes to the NHS have been radical, then what's happening in Kenya is a completely different ballgame. From being a completely centrally run system, these 47 counties are just being given a block budget, being told they have this many staff and told to get on with it. So there will be 47 health systems. And that's happened in weeks. So it's a highly dynamic environment in which there is little information of note within the health system. And therefore, if people are to ask questions like, how many patients... So in Kenya, it is government policy that everybody admitted to hospital should have an HIV test, because it actually influences their care. Do we know how many people ever get that test? No, we don't. We have absolutely no idea. And the same is true for many other types of simple indicator. So we feel that we need better information. Our work has also shown that there's dramatic variability across place and across time in what's happening. We all know that illnesses are seasonal, and that particularly illnesses like malaria, but also illnesses like HIV have geographic hotspots. But we're not sure how much those contribute to underlying, or to observe variability in what the health system is really seeing. We've seen in pediatrics, in data that we've collected, mortality rates that vary by 400% across hospitals. But we have no idea why that is. We've got ideas, but we don't have data to understand that. Obviously, quality of care and safety of care are becoming more interesting. Even in Kenya, it's an aspiration of systems that they provide quality of care, but they actually don't know whether they do, because they don't have any measures. We talk about the roles of new technologies. With the government, we looked at over 20 hospitals last year, and something as simple as pulse oximetry, a little device that costs a couple of $100 to measure blood oxygen saturation, we could only find present in 3 out of 22 hospitals. So when people are inventing new technologies and thinking, well, there's a fantastic play, we can just give them away, or that doesn't mean to say anybody will use them or will be able to get them. But part of the problem is we actually don't know what technologies people have. Another example, which is not a technology per se, but a drug, so artesunate, which everybody in this room is probably aware of, is a lifesaver, much better than quinine for treating severe childhood malaria. Artesunate was made the drug of choice to treat severe childhood malaria, well, to treat severe malaria in October 2012, and to date nobody is using it. That's partly because there's a procurement issue, but actually from the current health information system we would never know whether people were using it because that data are not recorded. So we actually just don't know what's going on within the health system. So the bottom line is we need more data and it needs to be better, and to understand what's happening we need new methods of analysis. And ultimately, if we've got data, we can measure whether things are actually changing. So what we've set out to do is set up something called the Clinical Information Network in Kenya, which will take us a few years. This is a map of Kenya, and the counties are outlined by the grey lines, and the dots are hospitals that the Ministry of Health in Kenya feels it knows where they are. You'll obviously see that they're highly aggregated, and that's actually just a reflection of population density. So it's not necessarily true that the ones in the north of Kenya have fewer hospitals per head of population. But it's, the reason for putting this up was just to show that there are lots of hospitals. So there are more than 250 hospitals in the government sector and considerably more in the private sector across Kenya. And we know almost nothing about what they do. As part of our training and development of job aids some years ago, we worked with paediatricians to develop this simple kind of recording format, a structured form for when one of their junior staff admits a patient to the hospital. They do it in a structured way, which the idea is it links into the guidelines, i.e. what are they supposed to be doing with particular types of patients, but I'm sure you can also see that it makes for much easier data collection. So these have actually been introduced at a national level in policy, and in practice the uptake is much more mixed, but there are quite a few hospitals now using this approach to structure the initial work of the clinicians when a child is admitted to hospital. So this allows us to go in with some data collection tools. So what we have been doing over the last months is working with a set of hospitals to try and set up a system for collecting data on the patients in a much more sophisticated way than they've ever done before. On your bottom left there are 3 black dots. They're on the coast, and those are hospitals where colleagues from Kilifi have already set up various systems, and we hope to be working with those to try and incorporate what they get up to as a general framework. We've tended to work more in central and across to the west of Kenya, and the red dots are hospitals which we've already started working with, and the purple dots are hospitals that are on our target before the end of the year. So we hope to end up working with between 12 to 15 hospitals over the next 3 to 4 years in setting up this information network. We do it with the Ministry of Health and with the hospitals. So we don't send research teams out to the hospitals. The idea is to do this with the hospitals themselves. So the most input we will put into the hospital is one extra person for their health records office. And that's it. Otherwise everything else has to be done within the hospital and by the hospital. We're obviously working with the National Health Information System, which is interesting. We've been doing this for some years. The National Health Information System for Kenya, a country of 42 million, which is rapidly growing. There are 3 epidemiologists in the National Health Information System. There are far more in the HIV program and the malaria program than there are in the national system. But that's the level of capacity that they have. But having said that, I mentioned that things are changing fairly dramatically. There is an enormous pressure to use technology in Kenya, pressure and interest. So a large number of hospitals are actually going out and purchasing an electronic medical record system from a small software company that they might find in their town. So they're purchasing these systems for something like $20,000 to $40,000. They will often do a reasonable job of letting the hospital know how much money they should be collecting, and that's their main focus. but they do an extremely poor job of aggregating any data on what's going on inside the hospital. So part of our work is to try and work with some of those local software providers to engage them in providing the right data. So we end up dealing with a whole bunch of people in a whole different set of environments, with the idea that we become, with the ministry, a sort of hub for data, at least coming from these hospitals. We use the other thing we're trying to do is work as much as possible with open source software. So we use an open source software called REDCap for our data entry, and essentially with one clerk per hospital, we reckon you can get a pretty efficient system going of collecting considerably larger volume of data than they've ever had before on their patients. So the team from Nairobi, their system is set up so that we're able to, the people who are entering data are able to clean it on site. We use R, which is a statistical package, but again, it's open source, but we actually use it for running cleaning algorithms on site. We synchronize the data into a web server in Kilifi, and we can keep track of all the data that's being entered on a daily basis. So essentially, we're working up to having 12 to 15 hospitals entering data on a daily basis on every single childhood admission to that hospital, with a set of variables that will allow us to do to create reports for hospitals that they've never had before. These reports will be essentially feedback to the hospitals about what's really going on, but they also therefore provide a huge potential database. Well, they provide a huge database for analysis, both at the wider system level but also for researchers. So when this system matures, we expect to be getting about 20 to 30,000 episodes per year. So some of the things that these are just examples of some of the things we've been playing around with from work that we've done over the last couple of years, which has evolved into this network. So this is an example of the grey shaded area is the total number of admissions, in this case across 5 hospitals. And you can see what happens when we get strikes. So we had doctors' strikes and nurses' strikes in this particular period, during which time admissions dropped to almost 0, which means there was an awful lot of children, in this case, who were severely ill, who were not getting care. This kind of impact from events in the political sphere is rarely reported in our part of the world. The reason why the arrow there is there for internship is that the way medical people rotate in Kenya means that every 3 months the ward team is changing, which means in most African countries you get 8 weeks of training in how to look after a sick child in your medical training, and then you have to practice. A year and a half later, you're on the ward and you're the person handling that person, and your most senior person, a consultant or equivalent, is likely to be there 3 or 4 times a week, and certainly is not there sort of in the middle of the afternoon when somebody comes in who's extremely ill. So despite the fact that you've only ever had 8 weeks training, you are the person in charge when those serious events happen. So we're quite interested in the periodicity of practice, and whether there's a steep learning curve, or we hope there's a steep learning curve. And these are some of the things that we'll be able to analyse going forwards, because there is no such thing as orientation, no such thing as reminding somebody who's hasn't thought about paediatrics for almost 2 years that actually you need to calculate a drug dose based on the weight of the child. So there's great potential for mistakes, and we've, in one aspect of work for newborns who are given a drug called gentamicin, which is an antibiotic but which can have serious adverse events associated with it. More than 20% of doses that are prescribed are so high that one would worry that they could cause renal or hearing impairment. So, big data in that sense. I've talked about some of the things we'd like to be able to do, actually some fairly descriptive epidemiology, but also the quality of care indicators, and I've talked a little bit about adoption of different innovations. So again, this is an example of work from 22 hospitals, relatively small denominators, and some of you may be familiar with these forms of plot. They're funnel plots. So each point represents a hospital, and on the y-axis it's represented as a proportion, but obviously you can think of it as a percentage. So for this graph, it's the proportion of malaria patients who actually had a positive malaria test. So they're in hospital with a positive malaria test, and they're being given quinine, which is the drug of choice, and quinine should be given starting with what we call a loading dose. So the proportion is the number of children who actually were prescribed the correct form of quinine. So as you can see, there are quite a few hospitals, those in blue, which less than 50% of the time, and quite often less than 30% of the time, are using this drug in the correct way, although it's been used for 30 years. And the average, which is represented by the red line, is just a bit under 70%. So even for a drug that people have been using for 30 years, there's considerable variability in the success with which it's being used. But these kinds of data have not existed in the past. I mentioned that we have hierarchical data. We have multiple hospitals. In hospitals we have health workers, and each health worker sees lots of patients. So we'll be using these data to explore the variability amongst health workers. So I'll give you an example of why that makes a difference. If you want to change practice, broadly there may be two ways to do it. You either say, let's target the hospital as an institution, or we'll target the individuals as professionals. If the hospital, it's possible that if you target the hospital, people shift as a block within that place. If you change the way routines are in an institution, then maybe you can change the way everybody works. So, and that would be much more efficient than having to target each individual. If the institutional impact, if the ability of an institution to constrain what people do is very limited, then we're stuck with trying to change individuals. Needless to say, nothing's either black or white. So at the moment it looks like there's quite a lot of, even though you intervene at a hospital level, there's still quite a lot of room left for individuals to do what they like. So we're likely to have to think of more and better ways. And one possibility is for us to use our data collection system to target individuals for feedback. But that's just thinking of things as static events. Obviously, things change, and individuals within place change, and people learn. So we're also interested in the dynamics of how fast people change, how fast institutions change, but how fast institutions change. So if you arrive in an institution doing the wrong thing because you learned the wrong thing somewhere else, and the habit in your institution is to do the right thing, how long does it take you to change to do the right thing? So there's quite some interesting statistical modelling in trying to link person, time, place, disease, and different types of, and whether your behaviour is consistent across different practices. And to try and make things, we've also got an audience which is policymakers. So what we've been working on is a way of trying to give information in as concise a form as possible, but allows us to retain considerable explanatory power. So I'm going to try and lead you through this quickly. This is one of my PhD students' work. Essentially, consider you have 3 different types of illness. In most medical practice, there's a phase of what you do which is when you're trying to examine somebody or ask questions and find out what you think is going on. That's called assessment. Then you actually have to make a decision. I think it is this problem, or I think it is these problems. That's diagnosis. And then once you've made a diagnosis, then you plan a treatment. So you can conceptualize it as 3 steps in the medical process. And there's commonality in that generic steps, but obviously for each illness you might need to do slightly different things, and particularly obviously for diagnosis and treatment they will be different. Unfortunately, the way that the quality of care world has worked is to take every single component as an individual indicator, which means if you're thinking about, which we do, malaria, pneumonia, diarrhea, meningitis, malnutrition, etc., you end up with an huge long list of things you can measure to say, well, this was done well, but this wasn't done, etc., etc. But that doesn't make sense to people in policy. They want, well, just tell me how good they are. So what we're trying to do is come up with an index to say, this is how good they are. So that for a whole ward, for a whole set of diseases, you can say, this hospital is at this level. That's all the policymaker wants to know. The hospital might want to know, well, but where are they going wrong? And we want to be able to retain that explanatory ability. But this also provides for if we can create, and we think we have, create an aggregate index, it also provides an extremely efficient way of doing quality of care assessments, because you need far fewer patients if every single diagnosis can be aggregated into one indicator. And this is just an illustration of using this approach based on our previous trial. So the top, again, these are funnel plots, but vertically presented. There's only 8 hospitals. Each hospital is a dot, and this is the index. It varies from 0 to a maximum of 6, so it's a 7-point scale. And you can see the top figure is the baseline before the trial interventions had started, and you could see that 8 hospitals were tightly clustered around the red line, which is the average across all hospitals, and the grey lines are 95% confidence intervals for what you might expect from hospitals, which are derived from the sample of hospitals itself. So at baseline, all nice tightly clustered, one number out of a possible score of 6, hospitals on average got a quality score of 1.25. Not very good. Post-intervention, and the trial we ran was 2 forms of intervention rather than one intervention and one doing nothing. The green ones are the full intervention, and the blue ones are the partial intervention. So you can see everybody moves to the right quite substantially, and the green ones move further than the blue ones. So the second figure down is 6 months after we started, 12 months after we started, 18 months after we started. And what you'll see is that the green ones maintain their position, and there's some sliding backwards in the blue ones, but they're still much better off than they were when we started. So this is a quick summary of what the randomized controlled trial achieved using a new index that will allow us to report things much more succinctly than we have done before, but also provide an index that hopefully policymakers can rapidly scan and see these places are in trouble. What explains that variability? This kind of stuff. I don't have time to go through it, but essentially this is some of the qualitative work, and it's an awful lot depends on individuals within the system. In this case, different types of manager. Because what we measure is what happens, what do the frontline workers do? And so where we are now is both trying to set up an information system, but also trying to set up a what would theory tell us is the best way to intervene at system level? And for that would be a very long conversation, but we're dealing with issues of complex adaptive systems and dealing from politics down to personal incentives like motivation and pay, in trying to come up with something that we think, if you implemented at a national scale, would be influential. So we're putting in lots of feedback loops into the system which weren't there before, and we'll be testing the effect of those feedback loops. But we're also trying to move from the red dot to the blue dot, and we're trying to think on multiple dimensions about how you would move. So what we're trying to do is come up with generic approaches that will move institutions, in this case hospitals, from being not very good to being better, and those order generating rules should be able to work across place and across time. We can't, in complex systems, you can't, it's not like having a GPS and plotting exactly where you're going to be. You have to essentially set some constraints for the area you want to be, because complex systems don't behave in the way that we're used to in a much more systematic, mechanical ways of biology. I won't go through that. So essentially what we're trying to do is mix a whole bunch of things together in the group that's out in Kenya. And so we have a whole range of different types of people, and we're trying to build up links with people in Oxford. But it's not always easy finding out who does what in Oxford. And as part of that, as some of you may know, we've set up something, or initiated something called the Oxford Health Systems Collaboration. We hope to have people coming and going from the Centre of Tropical Medicine here down in the basement a little bit, and we'll be having a mini conference in Oxford early next year to particularly try and leverage some of the other skills that there are in and around Oxford. And obviously I presented a lot of things. A lot of it was done by a very large number of people, and it was not just me who should be sitting here. So thank you very much. That was it.